Candidates, how are you all? Hoping all are well. Is that my voice is clear, my dear candidates? Just ensure me.
Yes, ma'am.
Yes, ma'am.
Yeah. Okay.
Yes, ma'am.
Neurology session is little bit broad, so I may need two sessions. And in the meantime, most of the common question like stroke related, headache related, thrombosis related question. My MOH candidate and my Saudi license exam candidates. Heart and DHA candidates, for heart they will see the picture for the stroke related. Okay, so I'll take two sessions today and tomorrow, though this session was not according to the schedule, but I have to more emphasize this question because these are the maximum questions they ask in the exam. So tomorrow will be another part 2 and along with the question discussion. So regarding the common question, what I want to discuss, Guillain-Barré syndrome for DHA exam candidates, this is the hot topics. And CSF interpretation, also psoriasis exam candidates, because few questions they commonly ask, that's why I emphasize those topics. TIA, stroke, transient ischemic related attack and stroke related complication management, they rarely ask, but for my MOH candidates, they may ask regarding the investigation initially what will you do. So all I will discuss, it may need time, but keep patience and listen carefully all the words what I'm telling you. Discussion will not be short, it will be detailed because neurology is not easy to swallow everything. It's really hard. It's as I feel very comfortable in cardiology, but neurology is not like that. Okay, so best to know everything: brain location, systemic approach, complication. So I'm starting my session. iPad 6, kindly ensure your name. I always suggest do enter in my June with real name. Hmm? iPad 6. Actually, some rules very strict in which I have to focus. The name of iPad 6. Kindly unmute the mic and tell your name. Neither, if you mind it that after removing, I'll be sorry for that. iPad 6 candidates. Uh, I hope Dr. iPad is from my group, but best to introduce yourself. iPad 6. I don't want to waste my time. If I be strict, it is another way. Okay. So I'm starting my session from the brain area. If anyone complain regarding keeping in waiting, as I keep on iPad 6, kindly unmute the mic and tell me the name of the candidate and just ensure me who is he, okay, or she. Thank you, my dear candidates. Just listen carefully. So, brain area location function very important. Question they ask from the frontotemporal dementia, my DHA candidates, very important question. Actually, some question I always say importantly regarding the exam wise, because they ask more questions from them. So frontotemporal dementia, so we have to know the frontal lobe function. Higher order function, movement of body, personality. So when a patient develops frontotemporal dementia, she loses the personality. Speech problem, smelling problem, concentration, planning. So important thing is the planning, speech, smelling, and problem solving. Okay. So we have to know the frontotemporal dementia function. Second, actually I'm slow as due to many candidates entering and leaving, so I have to enter them, that's why. And after a while it will be speed up. Temporal lobe that receive and process sound, recognizing face. Long-term memory. So see very carefully.
Very carefully.
Brainstem is the main organ of the or main function of the brain, because it causes heart, it maintains heart rate, temperature, and breathing. So when I said patient in comatose, patient in unconscious, so all goes to a patient heart is not controllable. All are controlling via brainstem. Frontal lobe, temporal lobe, occipital lobe, we have to know in detail. Occipital lobe mainly function of the vision. Okay. If occipital lobe impaired, vision will be lost. Parietal lobe function will be the integrate information from different sense, touch and pressure. So touch pressure, if any person complained of touch pressure loss, taste sensation loss, we have to find out it would be the parietal lobe lesion. Okay, body awareness, spatial lesion. So exam question from the occipital lobe, from the frontal lobe, and temporal lobe. Cerebellum, always balance, coordination, movement is the function of cerebellum. I will post all the pictures, the lesion differentiation in detail regarding the frontal lobe. If lesion, it causes this disinhibition, impaired memory, incontinence, grasp reflex loss, anosmia. If frontal lobe impaired. If parietal lobe impaired, these are the exam question: dyslexia, apraxia, agnosia, and dysphagia, dyscalculia. Patient can't do any calculation. Patient can move the body balance. Patient develop the any sensory impaired the smell, size, shape, body. This is the dyslexia, dysphagia. Okay, dyscalculia, calculation, the shape, weight, everything appreciation will be the diminished. Temporal lobe dysphagia, dyslexia, same as well, poor memory and hallucination associated with temporal lobe. Occipital lobe, I was importantly said that's regarding the visual agnosia, it's important, and visual hallucination. For the exam purpose, homonymous hemianopia. So these are the exam related part. Just keep focus. Okay. Cranial nerve nucleus, just memorize strongly where they situated. Cranial nerve 1 and 2 situated in the cortex. Cranial nerve 3 and 4 situated in the midbrain. 5, 6, 7, 8 trigeminal, then facial. So all, and there's a glossopharyngeal, all goes towards pons important. 5, 6, 7, 8 very important, because why? From 5, 6, 7, 8 trigeminal, abducens nerve, facial nerve, vestibulocochlear, glossopharyngeal. If any time patient develops stroke, which nucleus or which part of the brain impaired the function? So you have, they ask my MOS candidates from the pons, my DHA candidates they ask from the 3-4 midbrain. So I'm specify some questions, so look over it. Okay. Regarding the head injury question, very important question for the exam, must to get. Subarachnoid hemorrhage, subdural hematoma, epidural hematoma, must to know. Epidural hematoma, this extradural hematoma, my dear candidates, sudden fall, sudden skull fracture, RT related question or emergency based question. They ask my DHA candidates, my SLE candidates, just remember, they ask which artery commonly injured. Middle meningeal artery. Another very common question, my DHA candidates, and every candidates remember lucid interval. Commonly every day they are asking regarding the lucid interval, you have to understand the information. What is that? That after a RTA, patient develop unconsciousness, sudden regain the consciousness, again fall down unconsciousness. What is that type of injury? Dr. Afrin Keka, which type of injury it is and what is it is called? Dr. Dinakar, Akastha Dinakar. We have to understand the lucid interval for sure. Dr. Badhun is here.
Yes, ma'am. I'm here.
Dr. Badhun, my question is that a patient comes to your hospital with unconsciousness.
Okay.
The bystanders, the attendants told you that, ma'am, my cousin, this patient, developed unconsciousness after fall down, then regain consciousness and trying to do shopping because he was doing the shopping and sudden fall down, and again patient got unconsciousness. My question to
Okay.
you, what it is called and which type of injury patient developed?
Ma'am, it's called lucid interval.
And which, by falling down, doing shopping, which type of injury patient developed?
Head injury.
Same. Yeah, head injury. Is that subarachnoid? Is that subdural? Is that extradural? Which type?
Subarachnoid hemorrhage.
Never. Lucid interval
Hmm.
always extradural. Exam paid
Okay.
question. Never do wrong. Lucid interval always epidural or
Extradural.
extradural. Clear?
Clear, ma'am.
Thank you. Thank you, Dr. Badham. So
Thank you,
I
ma'am.
discussed with Dr. Badham the scenario. This is DHA everyday question. Lucid interval, which type of lesion? Where is the lesion? This is. So lucid interval, lesion is the extradural hematoma. Okay. Chronic subdural hematoma. Chronic subdural hematoma patient is important cause elderly patient or patient if taking warfarin. These are the background information you have to know. Elderly patient or patient warfarin, patient sudden fall or frequently fall down. This word of frequent they will emphasize because chronic subdural hematoma means chronically it's not 1 or 2 days. So gradually hematoma ongoing cause minor fall every day. Every day patient falling down. Same scenario in the exam. Minor head injury, minor fall. Slow onset of symptoms. So, subdural hematoma question, my dear candidates, exam question, elderly patient develop chronic fall down. There is a history in exam question. There will be history chronic fall down or minor fall and slowly develop symptoms. It never acute onset. Chronic subdural hematoma, some association. One of the most common exam question is the polycystic kidney disease. Patient inherited or patient have family history of autosomal polycystic kidney disease. That's why this is associated with subarachnoid hemorrhage. There's a bleeding. So chronic subdural hematoma, subarachnoid hemorrhage, both are goes together. It's the most common due to the bleeding, by which we have to do differentiate. First of all, is there any family history of not polycystic kidney disease or chronic fall down for the chronic subdural hematoma? So how patient come to my hospital? Chronic subdural hematoma patient will come to your hospital elderly, warfarin, but subarachnoid hemorrhage patient come to your hospital with patient has family history of no Ehlers-Danlos. Though Ehlers-Danlos question never come in UE exam question, they always ask from the polycystic kidney disease or excessive alcoholic. These are the important risk factor for sudden spontaneous severe bleeding of the berry aneurysm. Where is the site of the bleeding? Site of the bleeding is the berry aneurysm due to patient has history of the polycystic kidney disease. Severe worst headache of the life. Exam question this word. Worst headache of the life. It never subdural. It never epidural. Worst headache of the life. It is due to subarachnoid hemorrhage. Thunderclap headache. These are the clue of your exam. Severe onset that never fell before. Occipital area, photophobia, vomiting, collapse, seizure, these are the complications. So we have to do the CT scan without contrast. If inconclusive for subarachnoid hemorrhage, we have to do lumbar puncture to see xanthochromia exam question. We have, if we can't find out by CT scan, we have to do the lumbar puncture for xanthochromia. And medication For vasodilation, we have to give nimodipine. There is a cerebral vasospasm, so we have to give nimodipine. Example 1 will be discussed with me, Dr. Akansiko. Try to be active. Dr. Ikra.
Hello?
Yes,
Dr.
ma'am.
Akansiko. Yeah, okay. Dr. Ikra, I'll ask second question. Dr. Akansiko is here, right?
Yes, yes, ma'am.
Yeah. Example 1, you will read and you will tell me your diagnosis and management.
Okay, a 40-year-old woman presents with a sudden onset of severe headache and recurrent episode of vomiting. She suddenly collapsed 1 hour after taking paracetamol. Her medical history is significance of Ehlers-Danlos syndrome. The
What is your
likely,
diagnosis?
the likely diagnosis should be subarachnoid hemorrhage.
Due to why? What is the predisposing factor for having subarachnoid hemorrhage?
One of the features here says that her past medical history is Ehlers-Danlos syndrome. Then now that
Excellent.
she's also having a sudden collapse,
Mhm.
then she's an elderly person,
Mhm.
being a 40-year-old person, then severe headache, there's severe headache, recurrent history of vomiting too, so which is suggestive of subarachnoid hemorrhage.
Hemorrhage. Excellent. So how you will investigate this case? What you have planned to do?
The first thing I would like to do is to do a brain CT.
And if it's inconclusive, what you will do?
A lumbar puncture will be advised, will be suggested, ma'am.
Do you know how long we have to wait for lumbar puncture to see genthochromia? The duration?
I'm not sure.
Around, if I say 6, 12, 8, what will be your answer?
I'll go for
You
8, ma'am.
Okay. Actually, if inconclusive CT we find out to appear genthochromia yellow protein like in lumbar puncture, it takes time 12 hour. Very important exam question. 12 hour. So, doctor, how you will manage? What you will do?
Well, from your conclusion, ma'am, we can give nimodipine for this patient.
Nimodipine for this patient. Excellent.
Yes, ma'am.
Dr. Akansika, thank you very much. You done very well. Thank you. You are very
You're welcome.
active. Yeah. Dr. Ikra, example 2 is for you.
Yes, ma'am. A 35-year-old man was hit by a car and lost consciousness. When the paramedics arrived, he was found to regain consciousness. However, his GCS suddenly deteriorated again and went into unconsciousness while in the A&E, with his left pupil being dilated and unresponsive to light.
What is your diagnosis?
Ma'am, it shows lucid interval and epidural hemorrhage,
Your diagnosis. Okay.
along with third nerve palsy, I think.
Okay. Excellent. Excellent done, Dr. Ikra. So, how you will manage?
Mm, Ma'am, first we go for CT scan brain, CT brain.
CT brain. We will do CT brain and evacuation for
Yes,
management.
management.
Excellent done. Yeah, excellent done. This is the third nerve palsy here.
Thank you, ma'am.
You're welcome, and you nicely got it is the lucid interval. So these are the point Dr. Akinsiko nicely said. It's Ehela Denler, so it is Benny and sudden. So these are the clue. We have to catch this clue for our exam. If I understand there is a lucid interval ongoing, this is the paid exam question. My MOS, DHA candidates, this is every day are asking regarding the chronic subdural hemorrhage. Regarding the epidural hemorrhage, Dr. Ikra said, chronic subdural hemorrhage here, the answers, example 4, I'll discuss later, but I want to share the scenario even. Chronic subdural hemorrhage, extradural hemorrhage, epidural hemorrhage. Why? Epidural hemorrhage pictures there. Lucid interval that lost of conscious but spontaneously recovered, and she has severe headache, episode of vomit, slow response. So see, they didn't give the clue that patient again loss of consciousness, but lucid interval, you may ask, ma'am, patient still didn't loss of consciousness. So how I can manage? So if they said regain consciousness and Jesus suddenly deteriorated, went towards the unconsciousness. So see, consciousness, unconscious, this episode. Even they can't give. Like example 3. Only they said here hit by a ball, initially loss of consciousness, spontaneously recovered. But it's also a type of what? Example 3. Slow response. It is type of what? It is a type of again extradural hemorrhage. Same type. Okay. Chronic subdural hemorrhage question C. We can discuss, though I already said the diagnosis, but best to find out the cause why this is the diagnosis. So Dr. Omer is here. Omer, Dr. Sashma.
Yes, ma'am.
Yeah, Dr. Sashma, you will read this question. Already I discussed the diagnosis, but you will tell me why this is the answer. You will give me details.
A 68 years old man became confused over a period of 2 weeks. He used to be active and go for long walks. Now he stares at the wall, barely talks to anyone, and sleeps the majority of the day. His daughter recalls that he fell down the stairs about a week before these changes happened. So
See, doctor,
the
yeah, what happened? Yeah, tell me.
um,
What actually
the
happened?
scenario suggests the subdural hemorrhage because there is history of minor trauma.
With,
Person
with
the
another important point, frequent fell down.
uh,
You
yes,
see, his daughter told that fell down the stairs about a week before. So, history
yes,
of fell down. So, you have
history
to
of fell
know.
down.
Okay. So,
Yes,
it's a chronic subdural hemorrhage. So example
hemorrhage.
5 for you. Tell me what is the point towards your diagnosis.
Lady found her 68-year-old father at home in a confusional state with bruising on his left arm and unsteady gait. CT scan brains show a midline shift from the side of a clot. Here the patient is in confusional state and with bruising on his left arm, which shows there is a history of trauma. Thus,
Mm-hmm.
CT scan brain shows midline shift from the side of a clot. So there
Mm-hmm.
is a shift of the midline, which
Mm-hmm.
shows a hemorrhage. Uh,
Yeah.
so
Mm-hmm.
that's
So that goes towards
subdural hemorrhage.
subdural hemorrhage. Subdural hemorrhage. Even they didn't give any clue towards frequent fall. Only they say there's a bruise, confusion is still. So you can ask, ma'am, there's a bruise, me see it. It may be frequent fall before or patient fall down, but patient don't know the status. By this
Yes.
way, we have to catch out the question. Thank you, Dr. Sasma. Well done. The every
Thank you,
three
ma'am.
candidates done, excellent done. My dear heart candidates, see the picture very carefully. Elderly patient, recent fall down, subdural hematoma picture, exam question, heart candidates, and every candidate. Because I sometimes emphasize for each related exam, they may face every question, because every candidate may face every question, but sometimes I focus on that. So subdural hematoma, epidural hematoma pictures are there. Midline shifted. So subdural, epidural, midline shifted. You see here that the midline shifted. Crescent shaped hematoma, subdural hematoma, history of fall and anticoagulation or alcohol, elderly patients. So these are the subdural hematoma. My dear heart candidates, let's see very carefully, and every day they are discussing regarding the epidural, subdural hematoma and the same crescent shaped hematoma. So what is that? Okay, so you have to remember this way. Regarding the very important question regarding the middle meningeal artery, first of all, I want to discuss stroke related area and question they asked from them. And I'll post this picture later. Even anyone can take a shot, no issue, but I'll post later. Very important exam question for every candidate. Anterior cerebral artery, if this artery occluded, patient come to your hospital with contralateral hemiparesis. Means what? Means if it is right-sided anterior cerebral artery included, left side will be hemiparesis and sensory will be lost in left side. You have to remember this way, guys. These are the exam question. Lower extremity will develop more weakness than upper extremity. Medial cerebral artery, if impaired, my dear, can you just give me 1 minute? So listen very carefully that if medial cerebral artery stroke, exam question you can say for DHA, every candidate medial cerebral artery they ask commonly. Contralateral hemiparesis sensory loss along with upper extremity will be more weaker than lower extremity. Contralateral homonymous hemonopia means opposite sided homonymous hemonopia and aphasia there. Posterior cerebral artery stroke, it is associated with visual aggression, that is, they give this clue and it is important. Though they'll give contralateral homonymous hemonopia with macular sparing, no need to remember. Just remember visual problem is a posterior cerebral artery and another way it's the occipital lobe. Many questions I'll discuss later. Kindly keep listen carefully. Weber syndrome. Weber syndrome branches of posterior cerebral artery that supply midbrain. So, midbrain supplied by posterior cerebral artery, in which there is ipsilateral third nerve palsy, contralateral weakness. Weber related to third nerve palsy, actually we have to do easy, because if we remember everything it may be wrong. So do it. Weber, third nerve palsy, there will be the TOSI, there will be the dilated people, that's it, that's it. So you have to remember by this way. Contralateral weakness, you can see it can be associated with stroke. So main important point is the third nerve palsy. PICA, the name is posterior inferior cerebral artery or PICA, lateral medullary syndrome exam question. So PICA means posterior inferior cerebral artery or lateral medullary syndrome or Wallenberg syndrome. Ipsilateral ataxia, same sided, nystagmus will be there, facial pain, temperature loss. Okay, ipsilateral means same sided. Lateral medullary syndrome, my dear candidates, I always emphasize on facial pain with loss of pain temperature. Because why? We have to do shortest our information and we have to correct our exam questions. So, regarding the posterior inferior cerebral artery lateral medullary syndrome, we have to keep carefully remember that ipsilateral ataxia, nystagmus, ipsilateral facial pain, temperature loss, that's it. Anterior inferior, when my candidates will enter, kindly mute the mic. Anterior inferior cerebral artery is the AICA or lateral pontine syndrome. You can say PICA, you can say AICA. So AICA related to similar as Wallenberg, but there is a facial paralysis. I said how we can differentiate. We have to differentiate by AICA, PICA by presentation. In PICA, Wallenberg, there will be the loss of pain, loss of temperature, but in AICA, there will be the facial paralysis with deafness. Retina-ophthalmic artery amaurosis fuga, not so commonly asking question, and anterospinal artery stenosis, not so commonly asking question. They ask from the vertebral compression. These topics I'll discuss later. So my dear candidate, stroke by anatomy, my MOS candidates or all can keep a T picture or I'll post later in my group. Just keep carefully this very important topics for the strokes related. Vertebral artery dissection, my dear candidates, listen carefully. I will discuss shortly because I no need, and what I am telling, just keep emphasis on them because they ask what is the diagnosis, that's it. Vertebral artery dissection, we have to remember the clinical sign and the causology. But I don't care again in the causology, we have to remember the physical sign. Physical signs include nystagmus, Horner syndrome, hemiparesis, lateral medullary syndrome, already I discussed, tongue deviation, and ophthalmoplegia. If this kind of patient come to your hospital, the age will be within 45 or below 45. So, equal or below, under 45. The causology, it could be the any kind of tissue disorder like SCLE, any trauma. Actually, exam question they ask from the sudden injured, traffic accident, supporting injury, and you are emergency doctor. Patient come to hospital with ophthalmoplegia, with Horner syndrome, nystagmus. What is the diagnosis? Clean cut scenario. You can ask me, ma'am, why not A subdural, why not epidural? No, I didn't discuss regarding this type of presentation with any subdural epidural. I didn't discuss. I said only severe or worst headache in subarachnoid hemorrhage, and the presentation will be there and how we'll manage. Regarding the vertebral artery dissection, my MOS actually I emphasize some question my specific candidates, so no need to take anything another way because every question is important. Vertebral artery dissection always they give in the exam by any injury related. Connective tissue related, they never ask. They ask from the injury or sudden road traffic accident, sudden sporting injury, patient come to the hospital this way. What is the diagnosis? Even they didn't ask regarding the management or investigation. So only you have to remember the presentation and diagnosis. Stroke management, I'll come later. So injury related head all I discussed. So now very common exam question is the meningitis. Very important. My short note, my every candidate exam question. Just listen carefully and play the role. What is the note? I will never see color of the CSF finding. In my exam question, they said color is straw, color is cloudy. I will not never look at that. What is the color? Another, I will strongly say the glucose. Glucose low means it's a bacterial. That's it. I don't need to remember is it TB or is it bacterial. Glucose low is a bacteria. Third point regarding the protein. Protein high normal, I will not see. My exam question, two question. One was aseptic meningitis, another was bacterial, even it was TB. So you can say, ma'am, if there is lymphocyte present, is it TB? I say yes. If there is a neutrophil present, is it bacterial? I will say yes. So even they may misguide you by telling lymphocyte in bacterial. So you can ask, ma'am, so how I can differentiate? You have to do differentiate by background information from the TB and bacteria. For me, strong recommendation, see glucose first. No, even my TB question, CSF color will be what? Cloudy, but it was clear. Recent and recall even the two countries face same question, ma'am. Pattern was TB, but color was clear. I was said it was twisting question. You have to catch this question carefully. So do no need to see regarding the color. No need to see regarding the protein. I will check the is it glucose? What about the WBC variety? Is it lymphocyte present or neutrophil? You can say, ma'am, lymphocyte present in viral and TB both. So how you differentiate? It's easy. In viral, never glucose will be low, never. Straightforward question, glucose always will be normal in viral. So in bacterial meningitis, glucose will be low, neutrophil will be there and protein will be high. In viral, there will be the glucose normal, lymphocyte present. In tuberculosis, lymphocytosis will be there, not lymphocytes only or few lymphocytes. No, that's a lymphocytosis. Strongly recommended question for the exam. Every candidate should follow what I am emphasizing those topics. This is not short as well. Okay. So meningitis, gram-positive streptococci or diplococci, you have to know very carefully. Gram-positive bacilli associated with the listeria. They give this value exam. Gram-positive bacilli. Only gram-negative diplococci. So this is very important box you have to remember, my dear every candidates. So see another thing. Turbid purulent, no rash, think Streptococcus pneumoniae, but I don't want to follow this word. Turbid purulent CSC, even they don't give in the exam. So what I have to do? I have to see this positive diplococci. Can you mute the mic? Who will enter my session? Nice to mute the mic because it will be recorded and recording will be given. So best to do this. So gram-positive diplococci is the Streptococcus pneumoniae. Gram-negative diplococci is the Nischia meningitis. This is strongly point towards the diagnosis. Another is gram-positive bacilli, gram-negative coccobacilli. So this is the Haemophilus influenza and Listeria monocytogenes. Example 1 will be discussed with me, Dr. Somia is here. So Dr. Somia, you will read this example 1 and tell me what is your diagnosis. I am not hearing your voice actually. Kindly, you may be away from your mic, okay?
Okay, ma'am. A 36 years old male presents with the headache, increasing headache, photophobia, and neck stiffness. CT scan is normal. Lumbar puncture is done, and the CSF shows the glucose and with lymphocytosis. There is no organism on stain. So this could be TB meningitis.
Why? What are the clue here?
Clue is here. CSF shows a low glucose plus lymphocytosis, not just lymphocytes.
Okay. So main important strong point what? Strong point.
Strong point. Gradually increasing headache.
Next
No.
difference.
No. These
No
are never
organism
strong.
strain.
A meningitis strong interpretation I discuss and I recommend strongly regarding a point. Which was this point? A point we have to see strongly. What is that?
Glucose.
Why
Low
glucose?
Low glucose.
Lymphocytes there. You can say, ma'am, there is a lymphocytosis. But no, I said in viral, never low glucose. Okay. Viral, which type of glucose I'll find out?
Normal.
Normal. We'll find out the normal glucose. Like I will discuss few questions here, then it will be nice and it will be more clear then. So example 2 will be discussed with me, doctor. It will be nice if Afrin Keka unmute or Sabah Jason unmute.
Afrina Keka,
Afrin Keka, example 2.
25-year patient presents with one-day headache that has been increasing in severity. She cannot tolerate bright light and there is discomfort on turning her head. Cardiac sign is negative. Lumbar puncture CSF shows normal glucose, elevated protein and lymphocyte.
Lymphocytosis.
Lymphocytosis.
Tell me, what are the points towards your diagnosis? First of all, Dr.
Lymphocytosis.
Afrin, tell me this, what you find out and why this is your diagnosis. First of all, tell me what is your diagnosis?
Viral meningitis.
Viral meningitis. Excellent. Excellent done. It's a viral meningitis cause. What are the strong point here?
Elevated protein and lymphocytosis.
No. Strong point is
Normal.
glucose normal. Normal glucose. And this chart, if any my candidates remember that TB meningitis, lymphocytosis will be there, bacterial meningitis, lymphocytes will be, neutrophil will be there, but viral glucose will be normal.
Normal.
Clear, Dr. Afrin?
Yes, madam.
So these are the way we have to remember. Thank you, Dr. Afrin, you done good. Very important question. They ask commonly from the migraine or cluster headache every day. Every candidate. Tension headache, very rare, but commonly they ask from the cluster headache management and migraine management. So how they ask and what we have to know. I always emphasize those points, what we have to know. Even I'm discussing the glucose, but my candidates are forgetting. I don't know why. What is the cause? Because this glucose only strong point which goes towards the right answer. Even it will not the lymphocytes, it is not the protein. I'm telling within the 5 to 10 minutes of discussing same things that glucose we have to keep focus on the meningitis interpretation of the CS. So tension headache, bilateral, it is the pressing, tightening, dull nature, mild to moderate in nature, around 30-minute duration, so it's not long duration. Patient can do everyday activity with this headache. Normally we'll give this painkiller. This scenario, they'll give a clue patient on the financial or stress or familial crisis, bilateral headache, tightening headache. There's no refreshing sleep like that, so it's a tension. Cause duration is less, 30 minutes only. How you'll manage? We have to give the NSI on. Very important exam question, migraine. They give this scenario throwing unilateral. No need to remember bilateral. No, because still now bilateral presentation of migraine. They didn't give. They asked rarely one or two recall I saw before. Hemiplegic migraine scenario. Within 15 days or 2 weeks back, can you just give me feedback regarding the hemiplegic migraine scenario? So nicely, she got the she can catch the answer because she was telling, ma'am, there is a severe headache, unilateral, all are regarding the migraine, but there is a paralysis of upper arm. So I'm thinking it's hemiplegic migraine. So nice to say she got the point. So hemiplegic migraine, they asked from the neurology associated complication. Pain intensity moderate to severe, photophobia, triggering factor, visual photophobia, speech disturbance, sensory symptoms, duration 4 to 72 hours. Patient prefer to sit dark room, limited activities and quiet room. What they ask? They ask migraine management, migraine prophylaxis. First line sumatriptan if more than 70 years orally, NSAIDs and combination therapy, NSAIDs or sumatriptan or paracetamol with sumatriptan. But prophylaxis exam question is beta blocker. Still they didn't ask from the topiramide, but you can keep in your mind. Another way they ask regarding prophylaxis beta blocker, Another way they ask that how you will manage initially. So initially, kindly see the option first. I always recommend my dear candidates, every candidate, my course, my tips, tricks, everything important. Every candidate follow my tips, tricks. First read the option A, B, C, D, E. Then read the scenario. By reading the option, you will exclude A is not answer, B is not answer, C might be, D might be, E is not answer. So answer C or D. And I am reading now question. So what will be the answer? So okay, this is initially definitive what is the answer. So like that way you have to practice. There is a lots of incomplete question scenario recall. No need to be puzzled. We have to be strong our knowledge and information. Then I can ace exam first time. No need to do second or third time. No need. Still no. So migraine prophylaxis beta blocker, triptan or topiramate if they give, no option beta blocker or patient asthmatic. They always ask twisted question. Sometimes 50 question in 150 question, 50 to 60 question will be the very easy. So and 40 question will be little bit difficult and 10 to 15 question will be very hard. So like that way we have to get 90 plus question correct. This is easy. Because 60 question if it is very nice, so it is nice and 30 question we have to correct more. So that is the way we have to correct our answer. So is migraine question, if I see initially I can give sumatriptan, but they didn't give sumatriptan, they only give NSAID, so mark it. That is the way we have to choose our answer. C option first, then correct the answer. So this migraine question I already discussed. Cluster headache question, just remember the presentation unilateral. Pain, variable pain on eye. Stiffness, there is a nasal stiffness, there's a very severe intensity pain, there's a pupil constituted watery red eye, rhinorrhea present, facial sweating, drooping eyelid, though still drooping eyelid, facial sweating, they didn't give, they give the red eyes, constricted eye with the rhinorrhea, nasal stiffness like that way, and the very severe intensity pain. Don't think it's sinusitis, no. Sinusitis presentation is not there because cluster headache, rhinorrhea, complication with this drooping eyelid, complication with constricted pupil, never in the sinusitis presentation. So we have to make sure it's a cluster headache duration almost 3 hours, but sinusitis duration only 15 to 20 minutes. That's it. So cluster headache duration important. Very important exam question, very important management. Acute phase, many candidates ask me personally, why oxygen I will give in acute setting? Why I will not give the painkiller? Actually, in acute setting, we have to give first 100% oxygen, then sumatriptan or nasal subcutaneous is another. First give oxygen, then sumatriptan if needed. But prophylaxis they ask, it's the verapamil. Exam candidates and my dear every candidates, don't be puzzled. Acute setting is the oxygen, and along with it they ask the combination oxygen with sumatriptan, oxygen with subcutaneous sumatriptan, mark it. Neither if they give initially what will give only one option 100% oxygen, second option sumatriptan, mark first oxygen. Sumatriptan we give for relieving the pain, but best to give oxygen first, then sumatriptan. Prophylaxis we choose verapamil. Okay. So example 1 will be discussed with me, Dr. Donilda. Example 1.
Yes, ma'am. Yes, ma'am. 34-year-old female presents with history of recurrent attacks of intense headaches. They are usually unilateral, pulsating, associated with photophobia and vomiting.
What is your diagnosis?
This is a case of migraine.
Excellent. What at that
Yeah.
point?
Vomiting and severe intense headache and photophobia.
Main important point, doctor, recurrent, intense headache and
Headache.
unilateral with pulsating in nature. Pulsating word very important. Okay.
Yeah, pulsating. Yeah,
Photophobia, there is aura. Photophobia
yeah,
is aura.
aura. Right, right.
Yeah,
Yeah, okay.
excellent. How will
Yeah.
you manage, dear? What is the management plan to you?
First, 100% oxygen.
It's a
Then,
migraine, dear. It's not. It's a migraine. It's not a cluster headache. It's a migraine.
okay, sumatriptan, nasal or
Excellent.
subcutaneous, depends on the
Excellent.
age of, if it's more than
Okay.
this, you can give
Mm.
nasal. And later, topiramate if
It's a
beta blockers.
prophylaxis. Beta
Beta
blocker.
block,
Excellent.
beta blockers.
Excellent.
Yeah,
Excellent.
okay, yeah.
So, Dr. Donila, see, you already mismatched with cluster headache, but don't do so. Cause why? So, what
Okay,
also with cluster headache, but it's the second option.
yeah, yeah.
Oxygen also option for the cluster headache, not for the migraine, right?
Yes, yes, okay, right.
Uh,
Yeah,
yeah. Thank you, doctor.
thanks,
Thank
ma'am.
you.
Thank you.
Yeah. Excellent.
Yeah, thanks.
Thank you. Dr. Sabah Jisan is here. Sabah Jisan. Exam candidates should always be active because live session very important to know the mistakes. Sherin, John, or Priya.
Yes, ma'am. Sharon John.
Okay. So Sherin, John, example 3 for you.
Example 3.
Yeah.
19-year-old female has episodic headache preceded by fortification spectra and can sometimes last for 2 to 3 days. The most appropriate treatment in this acute phase.
So first of all, Dr. John, tell me what you are thinking of the diagnosis. What happened here?
Ma'am, is it a migraine?
Why? What are the clue?
Because it is episodic headache and lasts for 2 to 3 days.
And the fortification spectrum means there's a predisposing factors. Spectra, if you the patient present with the photophobia, phonophobia, like that. Fortification of
Okay.
spectrum. Okay.
Okay, ma'am.
So
Okay.
there is the aura. There is aura. Okay.
Okay.
So how you will give initially as you are doctor, patient come to your hospital. Now what you will give?
Initially start with the sumatriptan.
If triptan not given, how you will manage this headache?
Um with NSAID.
NSIs. NSIs. Okay.
Okay.
Say excellent done, Dr. John. So first of all, Dr. John, see the fortification of spectrum is aura. Migraine is aura. It's our point of view for diagnosis of the migraine. Second, how I will manage, you excellently tell ma'am I will give triptan, but I said triptan is not in your option. You can't say A, B, C, D, there's no option of triptan. So you have to, even in Viva, after passing exam, they ask many questions. Triptan is not working. What you will give? NSAIDs. What you will give? NSAIDs not working? Aspirin. This is the consequence of Viva question. So you have to remember everything. A patient severity, your job in the clinic, so you have to manage every day 20 plus cases every day. So you have to manage them. It's NSAIDs not working, give aspirin. Aspirin not working, give triptan. That is the way. Okay. Everything you have to keep clear. Thank you, Dr. John. Nicely done.
Thank you. Thank you.
Example 4 will be performed with explanation, Dr. Its name is Dr. Pallavi is here. Yes, ma'am. Example 4 for you.
30 years man presents complaining of severe headache in the last 2 hours ago. It is localized to the left side and associated with photophobia. He suffered from a similar episode a few months ago that had also involved the left side. It had lasted for several minutes for several times a day for a period of 2 weeks and then subsided spontaneously. The patient is unable to stand still, agitated, and anxious.
What is your
Mm,
diagnosis?
cluster headache
Why? There's a
because
photophobia,
okay,
unilateral. Why not migraine?
spontaneously subsided
Mm-hmm.
and anxious
Mm-hmm. And duration.
then
Duration
duration.
is very
2 hours. Last
longer.
2 hours.
2 hours.
Ji.
In migraine, duration will
Yes.
not be like that. Okay.
Yes,
Excellent,
ma'am.
done. Duration is very important. Cluster headache duration 50 minutes to 30 minutes. For migraine, it will be within
Within 2 to 3 days or
2 to 3 days or
2 3
more.
more. Ji.
Okay.
Yes. Yes,
Okay.
ma'am.
Thank you. Excellent, done. So actually, important point is the duration. We have to
Duration.
emphasize that duration. You nicely say, though there is a no nasal stiffness, though there is a no red eye and rhino, there is no typical presentation. They
Yes,
said on
ma'am.
agitated, spontaneously resolve, and you can mismatch even if you don't know. But we have to be strong with duration. Sometimes
Duration. Yes,
presentation
ma'am.
will be the atypical presentation, like this case, atypical presentation. Okay.
Yes, ma'am. Ji. Yes, ma'am.
Okay.
Thank
Excellent.
you.
Thank you. Thank you. Fatima Pari is here.
Yes, ma'am.
Fatima Pari will discuss with me example 6.
Example 6. Okay. A 30-year-old female present with complaining of recurrent headaches. These headaches, usually unilateral, last for 24 to 48 hours, have pulsatile character, associated with nausea and photophobia, and usually requires her to limit her activities.
What is the diagnosis?
It may be the migraine
Why?
because of pulsatile character,
Excellent. Excellent.
unilateral, associated
Excellent.
with
Photo.
photophobia, nausea.
Excellent. Okay. How will you manage? What you will give?
Uh, this 30-year-old, so we give sumatriptan first.
Excellent. If it's not in your option,
It is we give NSAIDs.
NSI. Excellent. Thank you, doctor. Nicely done, Dr. Fatima Peri. Another Fatima is here, I think. It's a Fatima, another. It's a Fatima 1, 2. I actually remember getting the Fatima Peri from the heart candidates, DHA candidates like that way. Actually, I'm really sorry by not recognizing. Another only Fatima.
Yes, ma'am, I'm here.
Okay. How I can recognize the Fatima Peri 1, Fatima is another. Okay, fine. So dear, read it.
Uh, while he is working in his of a 31-year-old suddenly developed
Yeah.
a 31-year-old suddenly developed excruciating headache to his left side associated with left eye pain. He experienced similar episodes 3 months ago. His left eye is red, swollen, and with lacrimation.
What is the diagnosis?
Ma'am, it's the cluster headache.
How will manage?
The management is with the somitriptan. Firstly the
No. Patient
firstly the
oxygen.
oxygen.
Patient come to your emergency. You are emergency doctor. What you will give initially? This is the exam question. Initially, what you will give?
Initially, first we will give the oxygen with the oxygen
Then,
in afterwards.
then
Then we have to manage
somatriptan.
with
Yeah.
somitriptan.
Excellent done. Thank you, Dr. Fatima. Thank you. Multiple sclerosis question they ask from the management, but we have to know the presentation. So multiple sclerosis question is very important, and multiple sclerosis, motor neuron disease, Guillain-Barré syndrome, myasthenia gravis. All I discuss shortly because these are the lots. No need to remember lots. We have to shortest. how we have to appear and how I have to correct the question. So multiple sclerosis, we have to remember that it is a chronic cell-mediated autoimmune disorder, demyelinating disease. Demyelinating disease means what? In our nerve, there is a cell covering myelin sheath, spinal cord and brain. When this myelin sheath demyelinated, this is loss of myelination, central nervous system. It could be relapse remitting. It could be the only relapse in nature. This is three types. But age is important and sex important. Women are the suffer more. Age within 20 to 40. They ask the diagnosis by optic neuritis along with pins or needle, numbness, trigeminal neuralgia, and paresthesia. My dear candidates, what are the important points? Because if you read all, you can do wrong. But remember, optic neuritis is the strong point towards the multiple sclerosis. It can present to your hospital with spastic paraparesis, spastic type presentation. It's the upper motor neuron lesion. My dear candidates, you can ask what is the upper motor neuron lesion, what is the lower motor neuron lesion. I am telling shortly before that upper motor neuron lesion mean spastic type. It's not flexed type. It's lower motor, it will be the flexed type. In upper motor neuron lesion, patient present with fasciculation, reflex will be high, jerk will be high, rigidity will be there. I already point out 6 points: hyperreflexia, hypertonia, and spastic rigidity nature, and upgoing plantar. Babinski sign positive. But for lower motor, it will be the how much in MND patient commonly present if sometimes both presentation, upper and lower both, but sometimes lower, MND variety. So lower motor is the hypotonia, hyporeflexia, Babinski negative, flaccid type paralysis, loss of tone, hypotonia. So why I'm telling the basic? Cause you can ask, ma'am, spastic means what? Spastic means is upper motor neuron lesion. In multiple sclerosis, ataxia, tremor, dysarthria, nystagmus, cerebellar presentation along with motor and spastic nature. Urinary urgency retention, sexual dysfunction, intellectual disorientation all goes towards the multiple sclerosis. But commonly how they ask 25-year female come to your hospital with eye pain, spastic paralysis with left side, and there is a rigidity and there is ataxia tremor present. What is diagnosis? So like that way, sir, multiple sclerosis. So cerebellar sign is very important, ATD and ataxia tremor nystagmus. Truncal ataxia along with the brain stem, if there will be the ataxia and dysarthria brain stimulation in the multiple sclerosis. Transverse myelitis I'll discuss later. Transverse myelitis, why it occur, I'll discuss everything later. First of all, multiple sclerosis presentation, optic neuritis, pale disappearance, acute unilateral visual disturbance. This is the clinical diagnosis. We can do MRI. They ask demyelation or lesion. We can find out in the MRI. We have to give the methylprednisolone IV from in acute onset. If it is chronic onset, we can give orally. Long-term glatiramer citrate exam question, interferon beta exam question. Okay. Example 1 will be discussed with me. Dr. Kishori. Dr. Kishori is here or not? If Dr. Kishori is not here, Dr. Reza Oruzi.
Yes, ma'am.
Yeah.
Hello, ma'am.
Dr.
Okay.
Yeah, Dr. Kishori, are you here?
Yes, ma'am.
Dr. Reza, I'll give second slot to you. So Dr. Kishori, read this question. Second half question, I will tell you and you'll give the answer. Start question.
25-year-old male present complaining that she has a progressive stiffness of her left leg. She also mentions that she has recurrent blurry vision that resolves
Resolve spontaneously. That resolve spontaneously. And in ophthalmoscope you done and it revealed pale disc. In lower motor examination you done which revealed 3/5. And you done also reflex and plantar. You see there is a Babinski sign positive.
Okay.
What is the diagnosis?
If
First of all, blurred vision resolve spontaneously. Ophthalmoscope finding pale disc. Lower limb examination finding 3/5 means there is a lower limb power diminished.
loss of tone.
And there is a Babinski hypertonia and Babinski sign positive. What is the diagnosis? How you will manage?
Is it upper motor neuron lesion?
Okay. And what is the diagnosis by seeing this case?
It's multiple sclerosis.
Why? What are the point?
Because here the patient is female. Where is no? And she's 25 years. The strong point is 25 years, and the female, and another is stiffness to her left side, and other is Babinski sign positive.
Positive. Babinski upper motor neuron. It's the upper motor neuron. It's a relapsing remitting type, right?
Yes,
upper motor neuronation. So how you will manage? What drug you want to give now?
Ma'am, first we give methylprednisolone.
Methylprednisolone. If I said patient is long-term case in your clinic, you are a doctor. What drug you want to give? Exam question. Long-term scenario, patient come to your hospital, follow up, but it's not relapsing, remitting, it's again relapsing. So how you will manage for this case?
Best is the steroids. If relapse, we can give beta interferon.
Beta interferon, excellent done. We have to give beta interferon.
If relapse, yes, ma'am.
If relapse is beta interferon, we have to give. If I ask Dr. Kishori, can you tell me one investigation point by which you can see anything you want to see?
As you have mentioned already, first, the best initial test, we do MRI. Even the accurate test is also MRI. But in MRI, we can see demyelination.
Lesion.
Yes.
Demyelinating lesion. Okay, excellent.
Yes.
Thank you, Dr. Kishori. Excellent done. Thank you.
Okay,
so Dr. Kishori done very well. So we have to remember this way: the stiffness, weakness, optic neuritis. There's a strong clue. There's a in ophthalmoscopy. There's a pale retina. In ophthalmoscopy, there's a pale retina, and there is the Babinski sign positive, plantar upward. So all goes towards the multiple sclerosis, variety of the relapsing remitting type. So we have to understand it's a multiple sclerosis. As I said, it is your case, it is your patient, how you'll manage long term. We have to ensure beta interferon is the exam question. Beta interferon we have to give. So we have to assess this way what they are asking. Okay. Few questions from the exam are important regarding the vestibular neuritis along with the labyrinthitis. Shortly, I will discuss because this commonly they ask from the ENT actually. Dizziness, vertigo, moving head. So it's a BP. If your head move, you are feeling dizziness. With moving of the head, you are feeling dizziness, BPPV, benign positional vertigo. Any viral upper respiratory tract infection is the vestibular neuritis. And you are complaining of vestibular neuritis, any history of the common cold, you are complaining of vertigo, you are complaining of hearing loss, so tinnitus goes towards the labyrinthitis. So vertigo and moving of the head without common cold is the BPVB. With fullness, deafness, vertigo, tinnitus is the Meniere's disease. Exam question, we have to do the MRI. Always MRI is normal due to the Meniere's disease. DVT and cranial nerve palsy is the acoustic neuroma. So just follow the tips and shortest the note how Meniere's disease question, exam question, a patient even DVT, forget it DVT. Just remember fullness, deafness, vertigo, tinnitus, pressure or fullness in 1 year. That's it. Meniere's disease. Cranial nerve palsy 1 point cause cranial nerve facial is a 7 nerve. Loss of corneal receptor is a 3rd nerve. Loss of facial sensation is a trigeminal, it's a 5. So 5, 6, 7. Which goes toward acoustic neuroma, vestibular schwannoma, cerebropontal angle tumor 5, 6, 7. Or 3, 5, 7 you can say. It depends. Corneal reflex loss means it's a 3, or if they say abduction, adduction abnormality, it's the 6, superior and inferior oblique muscle deteriorating. So 3, 5, 7 or 5, 6, 7 according to the scenario, but 5 means facial nerve palsy, 7 means facial loss of sensation is a trigeminal 5. So that is the way for the vestibular schwannoma, vestibular neuritis and labyrinthitis. Exam question, okay? BPVB already I discussed regarding the change of head position, pinning. We have to do exam question, how you'll manage or how you'll diagnose. It's the Hallpike maneuver treatment. Both exam question we have to treat by Epples maneuver. Hallpike's maneuver for investigation purpose, Epples maneuver for the management purpose. Varnish encephalopathy, only one question is it is chronic alcoholic, there is a vitamin B1 deficiency, thiamine deficiency, presentation, CAS, confusion, attaches queen. I have to give IV thiamine, that's it. Varnish encephalopathy question. CAS, we have to give IV thiamine. Stroke related question I was hold there and I'm starting those topics. Stroke. So my dear candidates, for the stroke management, clinical scenario, acute setting or transient ischemic setting. Tenecteplase or altiplase for thrombolysis and duration. Mainly we favor altiplase for the stroke thrombolysis. So for a stroke patient, we have to select someone if patient have this is actually basic care. We have to give the loading dose for the aspirin as soon as possible. If hemorrhage is stroke by excluded, we can understand it's not hemorrhage, it's ischemic because we have to do it. You can ask me how I diagnose it's not hemorrhage. Actually, a patient when come to my hospital for hemorrhagic stroke, it's the patient is not stable. Okay, patient come to the hospital weakness, dysarthria, ischemia. We can understand. They say within more than 4.5, we can give the loading dose of the aspirin 300 milligram. Okay, if patient on taking atrial fibrillation, patient warfarin, there's chance of having is hemorrhage. So we have to do, though this is the European guideline they follow, DWI MRI, diffusion weight MRI if patient come to my hospital within 4 hours to exclude hemorrhage. Diffusion weight MRI, this word commonly they don't ask, but if they ask, actually this is a very deep question. We can do exclude by doing. It's a commonly practiced everywhere, the diffusion weight MRI to exclude the stroke, thrombosis or hemorrhagic or not. Because if we do normal CT, normally MRI, it will not cause any effect on the brain, because within 3 hours or 4 hours, it don't show any occlusion. We have to do diffusion weight MRI to see is there any hemorrhage present or not. Second, so after this we have to thrombolize, or we have to give the loading dose of aspirin. So thrombolysis within 4.5 hours. The said imaging we have to perform for excluding hemorrhage, as I said, DWI. Just remember that way. Contraindication of thrombolysis just is a basic, just remember, and shortly you can remember or you can read by own self, because it's already discussed in the cardiology, same as thrombolysis in contraindication, absolute contraindication if there's hemorrhage, bleeding, recent stroke. Two exam candidates recently asking me, this is the exam question. A patient, okay, I'm giving a scenario. This question will be discussed with Dr. Sabah Jisan is here. Dr. Sabah Jisan is not here, right? Dr. Rita Rani. Rita Rani, okay, Dr. Reza, you can discuss with me. You were, unfortunately, was missed on the time.
Yes, ma'am.
Yeah, Dr. Reza, your question, 65-year, it's the exam question of your DHA. 65-year-old gentleman come to your hospital on emergency, you are emergency doctor, with 3.5 hour hemiparesis. 3.5 hour hemiparesis, then history of stroke 3 months back. How you will manage? What you will give? Management.
First of all, I think we must give to him anticoagulant.
What type of anticoagulant? Do you know what is anticoagulant? Tell me one name of anticoagulant.
Warfarin.
Why you will give warfarin here? What is the role of warfarin? Is there any atrial fibrillation?
No, aspirin and warfarin because of the.
There is no role for warfarin, no guideline as warfarin. I said 3.5 hour hemiparesis, history of stroke 3 months, how you will manage? Time duration 3.5 hour.
I have no idea.
No, you have to tell me step by step. Why you will not do it? Why you will give it? Why? What you have to plan? Because you have to tell me. Because this is the exam DHA question, recent exam question, and many candidates asking me. I am very unfortunate why they are asking like that way. So you have to tell me the answer. You can take help from our candidates, but you have to keep unmute. Dr. Kusia is here. Dr. Kusia, Dr. Hira, Dr. Maha Umar.
Yes, ma'am.
Yes, okay, Dr. Yeah, Maha Umar, Dr. Hira, all are here. Just keep unmute and we will discuss one by one. Dr. Hira, what you will do?
Ma'am, he presented in less than 4 hours. So we can do first MRI to differentiate if it's an ischemic stroke or hemorrhagic stroke.
Patient is ischemic stroke, present to your hospital, ischemic stroke.
Yeah, ma'am. Ischemic stroke, we will give loading dose of aspirin.
Why not thrombolysis? Dr. Umer, why not thrombolysis? Do you want to thrombolize the patient, Dr. Umer? Exam question. Do you want to thrombolize the patient? Yes or no? Anyone? Dr. Reza, Dr. Hira, Dr. Umar was on my platform. They must ensure, would you like to thrombolize or not?
Madam, now Dr. Maha is here. We don't thrombolize the patient because patient present with
3.5 hour only. Below 4.5
yes, madam,
hour.
because patient present with and a history of ischemic stroke. So it's contraindicated in ischemic stroke that we thrombolize the patient. So we have to give the aspirin in ischemic CVA.
Oh, yeah, excellent, Dr. Maha. Dr. Hira.
Yes, ma'am.
What is your opinion? Are you same opinion with Dr. Maha, or you want to do thrombolize this patient?
No, ma'am. We go with aspirin.
Only.
Yes,
Can't do thrombolize this patient because patient have recent stroke 3 months. The same paid question in the DHA exam, recent question. Dr. Reza Uruzi. Dr. Reza is here. Dr. Reza. If Dr. Reza is here or not? I can see he is here. Best to tell, is it clear or not? First of all, we have to know the background information. Though patient come to for thrombolysis prior, window prior, below 4.5 hour, but it's the contraindicated due to recent stroke. So we have to understand indication, though I didn't discuss again the absolute and relative contraindication, but we have to remember this recent stroke, absolute contraindication. But this stroke related, bleeding related question, they mismatch you, they misguide you, don't do so. Strongly read it, absolute and relative contraindication. And for Reza, for you, strong recommendation, try to understand the background information, what they said and what I have to do. As I am a doctor, I have to carry the patient and I have to be confident because this patient will be in my hospital and I have to manage this patient. If no, so there will be no job in the anywhere. So secondary prevention, clopidogrel is the recommended. Though we do aspirin, but sometimes aspirin sensitivity we can do clopidogrel. That's it. Carotid artery dissection, just remember if there is a carotid stenosis more than 70%, we can do carotid artery enarterectomy. That's it. Just one point towards this if it is more than 70%. Transient ischemic attack, this guideline was ABCD2 method. No need to remember. Just one thing we have to remember that how we'll manage. Transient ischemic attack patient come to my hospital. If I do this method, excellent. ABCD method, age is more than 60, blood pressure 140 to 90 is 1 point, clinical picture is unilateral weakness, speech disturbance. Just for discussion, if anyone don't want to remember, it's okay. Diabetes presentation. So if score more than 4, we have to give aspirin immediately. If score within 3 or below 3, we have to keep the patient specialist assessment within 1 week. We have to do brain imaging. Is there an ischemia present or not? If it is below 2, we have to keep on care this patient and we have to treat this patient as a high risk of stroke. So remember strongly, if just for like a patient come to the hospital 65-year age, diabetic patient, dizziness, all goes towards more than 4. So I have to give aspirin immediately. Then I can do the CT scan. Then if it is below 3, we can do CT to rule out the causology. You can start the treatment. But main thing is that clopidogrel we can secondary prevention we can start, but sometimes it's still not documented. But aspirin even we can start. But the thing is that you can ask, ma'am, what I'll give. Aspirin first. That's it. If aspirin contraindicated or can tolerate, we can give clopidogrel. That's it. And start as statin according to the patient background information. So first of all aspirin, then clopidogrel. So hope all understand my discussion today. Tomorrow another part of this discussion I'll post the schedule. Tomorrow another extra class from the neurology. Tomorrow will be from the seizure, Parkinson and Alzheimer disease, and a few common question they ask commonly. Before that I want to discuss one or two questions. This question answer will be given by Dr. Still now didn't perform with me, Dr. Priya, Ritarani, and Tamanna. 3 candidates.
Ma'am.
Priya. Dr. Priya,
Yes,
read the
yes.
question.
A 73-year-old female with a history of recurrent falls at home and alcohol excess is brought to the emergency department due to episodes of confusion over the past 5 days. Between these episodes, she's apparently her normal self. On examination, her GCS score is 14/15 and she has nystagmus on left lateral gaze. What is the most likely diagnosis?
Tell me what happened and tell me the diagnosis.
Yes, ma'am.
Hmm?
History of recurrent falls, alcohol excess, ma'am. And she's having episode of confusion for the past 5 days also. And between the episodes, she's apparently a normal self. There's lucid interval here, ma'am.
No. 5 days. Now, if lucid interval is unconsciousness, consciousness, sudden onset, but this is a recurrent fall.
Yes, ma'am.
This is the excluding method, the recurrent fall, an alcoholic patient. So, it's not Alzheimer, right? It's not herpes simplex encephalitis. So, what is the point towards?
And she's old female, 73, ma'am. Is it Alzheimer's disease?
Oh no, man. How? Recurrent fall, emergency department with alcoholic patient confusion. Come to your hospital. Read, think, Dr. Pia. Think and tell me. Dr. Tamanna.
Subdural hemorrhage, ma'am.
Okay. Why subdural? Dr. Tamanna, keep unmute. I'll discuss it here. Why subdural? Why subdural? Dr. Tamanna, why subdural? Dr. Tamanna, do you know the point towards subdural?
Yes, ma'am, because patient having recurrent fall and alcohol excess.
Excellent.
And
confusion.
Confusion, yes.
And GCS good, and there's a nystagmus present, left lateral gaze, okay. So third nerve palsy, third nerve degeneration also. So what all goes towards subdural. My dear Pia, always remember recurrent fall, only this word, even if you don't know, only this word, recurrent fall, subdural.
Yes, ma'am, I'll remember.
If you don't know it is a lucid or not, don't mark epidural. You see there is no epidural option.
Yes, ma'am.
It's not subarachnoid. There's no adenose presentation. There's no ADPKT presentation. There's no variation. There's nothing. Clear?
Yes. Yes, ma'am. Yes, ma'am.
Last question for today. This question will be discussed with me, Doctor. Last question. Try to participate. It will be nice if we do wrong here. Rita Rani, Dr. Nandini Sharma.
Yes, ma'am.
Nandini, read it.
Yes, ma'am. A 29-year-old male, a man presents complaining of visual disturbance. Examination reveals the right superior homonymous quadrantopia. What is the lesion most likely to be? I guess it's related with the
Superior, right? Superior homonymous heminopia. So superior muscle. So right superior homonymous quadrantopia. So quadrantopia. So if I say this way, this is the eye, superior quadrantopia. So this one. If I say doctor, SO4, LRC, these are the manomies. LRC means lateral vector supplied by 6 nerve, superior oblique supplied by 4 nerve, superior oblique. So this says superior homonopsia. So fourth nerve injured. So it is trochlear nerve injured. So in which part of the brain affected?
it's midbrain.
Now I'm telling from this option, opticosmo, right superior quadrantopia, homonymous quadrantopia is left temporal, right temporal. So think. So I said from my first session, 6 nerve and 4 nerve. So SO4, so 4 means trochlear. So which part of brain it is situated? Right superior. So it's a contralateral temporal. So it's the left temporal side. Left temporal side. If it is posterior occipital, there is no occipital. Okay, so it is the contralateral side of the left temporal.
Temporal. Okay, ma'am.
Just remember, left homonymous heminopia. This is a right optic tract. Homonymous quadrantopia is a piece. I already discussed parietal inferior and temporal superior piece already. Homonymous quadrantopia piece, parietal inferior and temporal superior. So temporal superior piece, homonymous quadrantopia. So lateral side. So piece. Remember piece. Parietal superior, temporal inferior. Okay.
Yes, ma'am.
Clear?
Yes, ma'am.
Though it was tough to you, but already we discussed and already it will be memorized. Thank you, my dear candidates. Hoping all really all done, every candidates. Tomorrow extra session from the neurology will be held in 9 p.m. BD. And in the meantime, I'll expose the mock question from the respiratory, and tomorrow will be practice from the recall question. Thank you so much. Good night to all.
Thank you.
Thank you, ma'am.
Thank you, ma'am.
Assalamu alaikum.